I'm at the outset, I'm thankful to the STEMI India for this opportunity to talk about the role of echocardiogram in STEMI. I would like to deal with on three items. One is on the diagnosis, number two on the prognosis, and number three on the complications. The criteria for myocardial infarction is based on a rise and fall of troponin along with another item. You will see here that it is said that you can have ECG changes, number one. You can also have a chest pain, and it has been now added in the fourth definition of myocardial infarction. You can look for a regional wall motion abnormality. So today's talk, I will just show you how this identification of the regional wall motion abnormality is useful in the diagnosis of myocardial infarction. This is a patient who came to our hospital last week with a chest pain of 30 minutes. And again, it recurred, but he came to our hospital within an hour. The ECG actually did not show any much changes other than a sinus tachycardia. However, when we did the echocardiogram, awaiting the troponin result, we noted that he has got the distal septum is hypokinesia and as well as the apex. So the echo diagnosis is easy, and we made the diagnosis of evolving STEMI much before actually the troponin came. It is said that we require around 95% block to have a patient with acute chest pain. If they have 90 to 95% of a transmural MI, they will definitely have a RWMA. This is another example of another patient where we noted an inferior wall RWMA in a given patient that came to us, which is confirmed along with the strain, which I will talk to you a little later. Now, there are several things that are useful in our measurement. One is the ejection fraction that is time ordered. It is said that whenever the ejection fraction goes below 40, there is an increase in the mortality curve. So actually, LVEF less than 40 is an independent predictor of death and the heart failure, and it is a very useful thing to do in our MI patients. Another useful parameter that we can use is the deceleration time. Here is an image of a deceleration time that is 127. It is said that whenever the deceleration time is 130, in a given case of STEMI or a myocardial infarction, it adds incremental value more than the ejection fraction. For example, in the group with EF more than 53 also, people who have restrictive filling, the survival is reduced. So whichever quartile you want to look at it, it is a useful thing to do. The next easy thing that can be easily done at the bedside in most of the machines is the E/E' ratio. This shows how 2 weeks after the onset of an MI, the E/E' that has been taken for a first-time STEMI has been shown to be a strongest predictor of survival or coming back with the pulmonary edema. Shown here is an example of a patient with an E/E' ratio of 21. Chest X-ray on discharge is normal, whereas 6 months later, the patient was got admitted with a heart failure pulmonary edema. So you will see in this graph on the right side that the E/E' ratio is a powerful predictor of heart failure coming up in a patient with STEMI, and it may be a good idea to start them on diuretics precautionary. We nowadays use the global longitudinal strain, which is relatively operator independent and is highly feasible, and most of the current machines have it. Shown here is a A4C and apical 2C and apical long axis, all showing a regional wall motion abnormality of the LAD territory. You will see that the GLS is only around 9. It is said that whenever the GLS is less than 14, it has got an increased long-term mortality and heart failure. The global longitudinal strain can also be useful in patients who will come back with heart failure later, just like the E/E' ratio. In this study, they have shown that a severely impaired GLS patient with a preserved LVEF has come back with a pulmonary edema, whereas the patient with a GLS that is normal did not. So the current guidelines have incorporated this into the document. You will find from the EACVA document that GLS, if available, should be considered in the echo report of all CAD patients, in particular acute coronary syndromes. And they said it has got a recognized incremental prognostic value over the EF in a chronic CAD as well as in acute myocardial infarction like STEMI. So this is to sum up the entire prognostic variables that are at the bedside available, namely an ejection fraction, deacceleration time, and E by E dash ratio more than 15. All of them will help you to decide on the treatment strategies as well. Let me move on to next to the complications that can easily be picked up with echocardiogram. Shown here are one, a papillary muscle rupture. It can be a ventricular septal rupture or an aneurysm formation and a free wall rupture. I will show you examples of all of them. It is said that this type of mechanical complications have come down from the pre-reperfusion era to the lytic era to the primary PCA era. Now it's only around 0.27%. However, you look at the mortality in this group of patients, it is said that the mortality is very high. This is the data from the shock registry. You will find that the mortality is around 60%. If it is VSR, it is around 87%. Shown here is an example of an anterior wall infarction with an apical VSR. This has got a, patients will be having may have a systolic murmur, may or may not picked up well. The patient also can be having in a shock if the shunt is higher. This is a short axis view of the same where the shunt is being seen. Moving on to the next case, this is a 54-year-old male who had an MI in 2002, inferior wall. He has got a class 2 symptoms. He's a diabetic and a current smoker. He has got a short systolic murmur and he has come for an evaluation. This image is from the hospital that I had worked earlier, Preston Medical College Hospital. Now you find that there is a ventricular septal rupture in the basal part. Chest X-ray, not much congestion. He didn't have any surgery. He came back later, namely 8 years later, again showing the same thing. It did not progress. But not all patients with a story is like this. Now, lysis, it can happen if patients are lysis, it can happen in the early part within 24 hours. It is possible in a wraparound LAD, the anterior wall. And with medical therapy, many of them do not survive long. This is a report from the August issue of the 2014 EHJ, which is given very nicely. You will find that the longer the period survives, the better for surgical mortality. Elective surgery done after 21 days, the mortality is only 10%, whereas an immediate surgery carried a mortality of 60%. So one treatment of these patients will depend upon the timing, the size of the ventricular septal rupture, with the larger the issue. And of course, as you know, patients can come back with a recurrence because of the dehiscence as well. Moving on, the other dreaded complication is a papillary muscle rupture. Shown here is a key image of a patient with a papillary muscle rupture. Papillary muscle ruptures are more common with the posterior medial one because it can be by single artery supply, RCA, or circumflex, in contrast to the anterolateral ones, which is supplied by the LAD as well as the circumflex. These patients present with acute pulmonary edema, if they do not get operated, they do die very fast. This is a patient. Of course, we always look for a mitral regurgitation and the follow-up because these patients can come with recurrent pulmonary edema. Lack of time, I'm not getting into the details how to do. I want to show you two more pictures that will stay in your mind. Namely, this is an inferior wall MI that was lysed. We did an angiogram, cardiomegaly done. This patient has got significant mitral regurgitation, posterior laterally directed, and you find a large aneurysm formation. So this can also be one of the features that you can pick up in a patient with a mechanical complication. This patient's angiogram shows right coronary artery that was occluded, and the LV angiogram shows the same thing that I showed you on the echocardiogram. Free wall rupture is a rarity, but the patient picking up is a rarity, but most of them will have got a high mortality. There are three types of ruptures have been recorded by Becker. Type 1 is a tear. Type 2 is again thinned out one, and type 3 is also shown here. Now, free wall rupture, the risk factors have been that they have got a, anterior MI, age is more than 70 years, and they are female. management is that you would like to immediately do a pericardiocentesis and do. This is a patient that we recently came across, a patient who the second day in the ICU suddenly developed a rupture, which a patient had to get to the theater to operate. Very small effusion, but you see the RV wall invigilation, etc. And the patient actually survived. And of course, one of the things that you can easily pick up is a LV thrombus. Now with the lysis and PCA era, it is very less, only around 2% or so. And TTE has got a pickup rate of around 1/3 to 50%. Contrast echo can pick up by 64%. This is an image that we will say is normal, but whereas a contrast echo shows there is a LV thrombus. Of course, MRI has got a higher sensitivity, approaching nearly 90 to 100%. And moving on to the RVMI. RVMI is another one that can easily be measured or can be made out in the echocardiogram by a dilatation of the RV, hypokinesis of the free wall. And we nowadays use strain to pick up this as well. The strain, important thing to note is that the basal segments are less compared to the apical segments. So the basal segment decreases to a greater extent than an apical segment. Lastly, I want to show you a very important image of a patient with an intramural dissecting hematoma, which is a very rare complication, which can be mistaken for thrombus as well. What you notice here is a cavity formation, and the wall itself is divided. It is due to intramyocardial hemorrhage separating the layers. And this is a thing, if you operate, it is a higher mortality. But most often it is said that if the patient can be managed conservatively, they may actually be better off. So in summary, I want to tell you, echocardiogram in STEMI is easy to do at the bedside. It is low cost and fast performance. It can be useful because you can rule out alternative pathologies. It can identify most of the complications. And you can identify high-risk complications by looking at the deacceleration time, ejection fraction, E/E' ratio. So we also use it to assess whether the patient needs ICD selection based on the EF at 4 to 6 weeks. Thank you.